So thank you for coming, and I'm looking forward to an exciting discussion and debate. I emphasize debate. I actually have never met the panelists until this afternoon, so I know it's going to be lively. And as the title suggests, the topic that will be the focus is the current and future impact of information technology on the delivery of healthcare. Huge, I won't say problem, but hugely significant. And I'm very pleased that our discussants and panel moderator agreed to participate in this first of an annual event. Hopefully it'll be annual, depending on Andy's impressions today. Okay. And many thanks to the Grove Foundation, represented by Andy and Eva, who were gracious enough to attend and sponsor this panel discussion today. You may wonder about the name of this hopefully annual series. Approximately 10 years ago, I started a course for UCSF graduate students entitled Anti-Medical School. For those of you who are bewildered by the term, the stimulus for the title of the course is my strong belief that medical schools teach students about principles of clinical medicine, which are represented as fact. However, a large component of this information is based on assumptions, at best, and that are not well substantiated, and they're based on unproven concepts. Moreover, there is little consideration of the significant needs in medicine and the opportunities to improve delivery of health care. And one of the panelists actually was a medical student here, so he can relate some of his experience here. Is Catherine Lucy here? No, okay, so I'll leave out the next well, I won't entirely leave it out. So I've been speaking with Catherine Lucy, who is the Vice Dean for the Medical School Education. And she told me about a week or so ago that she's planning a new track, optional track, for medical students that has a lot of overlap with the concepts embodied by Anti-Medical School. So I'm very excited about that, and I'll look forward to it's getting off the ground. Most importantly, there's been little focus on the thought processes involved in synthesizing patient data to arrive at semi-rational decisions rather than knee-jerk responses. So just out of curiosity, and of course you don't have to answer, how many people have ever been hospitalized? Okay, so I think you'll immediately be sympathetic to the problems, assuming that you've had a less than ideal experience, no matter where you've been hospitalized. When the joint Berkeley-UCSF Masters in Translational Medicine program was created and initiated by Andy and sponsored by the Grove Foundation, the Anti-Medical School course was incorporated into curriculum. The principles of the AMS include identification of significant needs in medicine, as well as how solutions for these needs are created. The course includes lectures by UCSF faculty who are experts in specialties that utilizes devices and IT in their practice. They discuss their needs and imperfect solutions that have driven discovery and inventions, and the many challenging needs that remain. I am grateful to our panelists, Ronnie, John, and John, and the moderator, Ahmed Guri, who has put in an enormous amount of work in organizing this. Dr. Guri is the CEO and founder of Interpreta, which is developing healthcare's first real-time platform for personalized medicine. He previously founded Anvita Health, which was the highest performance analytics engine in healthcare that was subsequently acquired by Humana, and he is a board-certified anesthesiologist. The way that I met Ahmed is that I take care of patients in the hospital at UCSF, and all of them are, to be in the hospital, very ill. And they're all extremely complicated on many different medications with many different illnesses. And the people taking care of them on the floor do not have the time necessary to figure out the problems, many of the complex problems. So they somewhat rely on arbitrary decisions. And I, in my primary role in that hospital, I'm a consultant. And it takes me a long time. And even then I know my suggestions are imperfect. So I got the idea that the artificial intelligence would hugely enhance delivery of healthcare, good healthcare. And I called a friend of mine who knows Sergey Brin very well, and she said, it's a great idea. Let's start a company. And she said, I'll call you after I talk to Sergey. And she said, someone's already done it. It was Ahmed, and she said, would you like to meet him? And I said, yes. And I was totally blown away by what he's doing. So, Ahmed, thank you.
Thank you, Mark, for that introduction. It's a great pleasure to help launch this first annual Marc Shuman Anti-Medical School Lecture. Just by way of background, this is a joint collaboration between UC Berkeley and UC San Francisco. And the topic today is the impact of technology and delivery of medical care in the 21st century. And I wanted to quickly, that'll be fine, that'll be fine. Mark, you unplugged the VGA cable.
I hate to say it, but that's typical.
Murphy's Law. So I wanted to talk a little bit about Dr. Marc Shuman, who's a great friend and a great mentor. He's a professor emeritus of medicine at UCSF. He's an esteemed mentor to countless national physician leaders, entrepreneurs, and scientists. He has a career that spans laboratory research, teaching, and direct patient care. He's at the front lines every day. He's been funded by the NCI as a principal investigator for 30 years, including research on proteases and cancer. And his previous leadership positions have included Director of Research and Education, Director for Program Development, Executive Steering Committee Head and the Prostate Cancer Program Leader here, the Chief of Adult Hematology and Oncology. He also co-developed the UCSF and UC Berkeley Masters in Translational Medicine program, but most importantly, he is a mentor, inspiration, and friend to so many people. And I also, of course, wanted to thank Dr. and Professor Grove, who, as most of you probably know, has been the co-founder, past CEO, and chairman of Intel. From very humble beginnings, became the CEO and chairman of what is the most successful and dominant microprocessor company in history. He's a leading physicist in the field of semiconductors, as well as a science of management. And I emphasize the word science of management. With a couple of quotes, with Intel, he helped to usher in an information revolution unmatched by anything since the invention of the printing press. He was Time Magazine's Man of the Year, and is being represented as the person most responsible for the amazing growth and the power, innovative potential of microchips. And he's also published several books, which you can easily find on Amazon, for example. So, Dr. Grove, we wanted to thank you for 3 reasons. The first is for sponsoring the event. The second is for enabling the dreams of millions of people by making supercomputing affordable and ubiquitous throughout the world. And the third is for teaching us the infamous Grove's Law, which is that technology will always win. You can delay technology by legal interference, but technology will flow around legal barriers. And because of this law, we can have talks like the anti-medical school, or we can discuss how do we use technology to circumvent establishments, to circumvent barriers, to circumvent laws that are human created to achieve progress. And so this is a very important law, and it embodies the spirit of this lecture series. So about our panelists, we have Dr. John Halamka, who is formerly the CIO and Dean of Technology for Harvard Medical School, who flew here from Boston to be at this lecture. We have Dr. John Madison, who's the Chief Information Officer of Kaiser, and Ronnie Zeiger is the CEO of a patient community called Smart Patients that is trying to embody anti-medical school principles, and is formerly the Chief Health Strategist for Google. Real quickly, Dr. Halamka is now the CIO of Beth Israel Deaconess Medical Center, one of the leading hospitals in the world, the chairman of the New England Electronic Data Interchange. He's also the chairman for data standards for the United States for all of healthcare. The panel is known as HITSP, and he's also a practicing emergency physician, so he's also at the front lines with patients. Dr. Halamka trained at UCSF Medical School, and also did bioengineering at UC Berkeley, and that's not a coincidence. That's a lucky coincidence, I should say. Dr. Halamka is on the faculty of Harvard. He's also a full professor. And these are in alphabetical order. Dr. John Madison is the CMIO of Kaiser, and in a nutshell, I'd just like to say that he deployed the largest healthcare information technology project in the United States years before medical records were thought even possible, involving 3 million patients, 140 clinics and 13 hospitals, multi-billion-dollar implementation. He received the HIMSS National EMR Game Changer Award for defining the pace of information technology in healthcare for the entire United States. And he's trained in internal medicine and critical care. And he's also co-founded the clinical document architecture, which is the standard, the international standard for sharing patient records in a structured way between institutions. Dr. Zeiger is the CEO of Smart Patients, which is an online community where patients and caregivers can share illnesses about complex problems, learn about treatments and the latest science in a non-paternalistic peer-to-peer way. Ronnie's also previously the Chief Health Strategist for Google, and he's at the front lines also. He sees patients part-time at Santa Clara Medical Center. He has an MD from Stanford and did internal medicine at UCSF. So he was well-trained. He's a clinical instructor at Stanford and has a master's in informatics from Stanford. Myself, Marc, gave a quick intro. I'm the CEO and founder of Interpreta, which is creating a real-time platform for personalized medicine that will process both a patient's longitudinal health history and their entire whole genome on a continuous basis, like a GPS, so that nothing can slip through the cracks at any moment in time. So what we're going to do is we're going to have a panel discussion for about an hour. We may circulate note cards, but I don't think we probably don't need to. We'll have questions at the end with both for Dr. Shuman and Dr. Grove moderating. And so what I wanted to do is get started with a series of questions. I'll toggle between the slides and darkness so that the panelists aren't blinded. And one thing I forgot to say about myself, I'm also an anesthesiologist, which is kind of good and bad. It's good because I've had a lot of experience working with lots of data, real-time, structured biometrics, but it's also bad because I'm known to put people to sleep. So I'm going to count on the panelists to help me out in this regard. And so the first question that I have, and again, the emphasis on all these questions, there's two parts to each question. One is, what can actually be realistically achieved within a time frame of 5 to 10 years? Not, we'll probably have our own personal genie in 30 years, but we're talking about 5 to 10 year time frame. And I'd like a clinical example as well as an approximate time frame of when you think that's possible. So the first question we'll go in order, Dr. Halamka, is how will big data, whether it's clinical genomic or patient created, help doctors make the best treatment or non-treatment decisions? And the key word here is non-treatment, because a lot of times watching is the smartest thing to do. If you can imagine, that's particularly important with slow-growing cancers. It may be important if you not to have a back surgery the first time you fall and hurt your back, right? So non-treatment is as important as treatment in many times. So, John, how would you?
Okay, I should start by saying, John, you know that my wife and my father and my daughter have all signed consent for me to share their full medical records today. So when I use these real examples, it's okay. You have complete privacy protection. My wife was diagnosed with stage 3A breast cancer in December of 2012. At the time, she was 50 years old. She is Korean. And you would think that in a learning healthcare system, you would be able to ask of the last 10,000 50-year-old women with stage 3A breast cancer, maybe if you were lucky with some genomic markers like estrogen positive, progesterone positive, HER2 negative, what were the treatments and what were the outcomes? And of course, in America today, asking such a question may be possible at an institutional level, but it's certainly not possible on a regional level or a specialty level. We just don't have that degree of big data integration. I'm not really sure what big data is. I have 3 petabytes. Is that big? I'm not really sure. It doesn't seem to be too hard to manage. What I did, because yes, as a CIO, I have access to 17 hospitals worth of data, kind of, your empire, very, very big. I was able to, as a CIO, go in and do de-identified data mining of about 10,000 patient records and discover that for her condition, including the genomic markers, that Taxol, Cytoxan, and adriamycin was a reasonably good combination. However, Taxol, very nasty drug. Many of the women who took Taxol in 9 doses, that's the standard protocol, developed neuropathies and had limited use of hands and feet, although cure, right? So you, of course, want cure. That's a good outcome. She is a fine artist. She does extraordinarily detailed paintings and drawings. Now, if you're a jackhammer operator, having neuropathy in your fingers, maybe that's okay. But a fine artist or a watchmaker, maybe not so okay. And so I asked the clinicians, what if she has 4 doses of Taxol as opposed to 9? They said, I don't know. We have no idea. No one's ever tried it. There is no clinical trial. Well, why do they use 9? Oh, because that was the dose that was given in the one clinical trial that exists. Well, why don't we try her on this combination of drugs, but with much less Taxol than normal, because she has care preferences, cure, plus artistry. And we did that, and she achieved complete cure. And today, while we're sitting here, she's actually doing very fine work in our beehives on our farm because it's finally 60 degrees in Boston and the snow is almost melted. And so you shouldn't need to be a CIO with access to 17 hospitals of data to answer this question for your loved ones. This should be common care in every electronic health record that you should be able to draw on the experience of the crowd and the experience of a country and derive evidence-based right treatment personalized to preferences and genome and medical records. I think we're going to head in that direction. I mean, we're starting to see creation of registries to scale with asking questions of a population nature. It's not that I'm asking for Ronnie's named medical record. I'm saying, of patients like Ronnie, what can I expect to see? So there's no IRB or HIPAA questions if it's de-identified at a population level. This takes work on standards, which John knows very well. But most importantly, it takes culture. It takes politics. Because, of course, there is this sense, if I do a query over the internet, there could be malfeasance. And how is it that we can ensure technical protections, but also policy protections and cultural expectations are such that a patient says, before I am treated, tell me what happened to the last 10,000 patients like me?
Beautiful, John. I have a question, though, corollary to that. In what kind of a time frame can we realistically believe that such a database might exist where we could query it? And I'll ask the same question to everybody. Where we could query it and say, you know what, find 10,000 patients that look like John or his wife and who have stage 2 breast cancer with certain type of genetic markers and show me what happened to them with different treatments. Is that a fantasy that is 100 years off? Is it 5 years off? 10 years off?
So John and I often work in political circles. And so is it regulation that changes technology or society? No, it is economic incentive. And in the world of accountable care, you're now seeing payment, especially we're seeing in New England, based on outcomes, based on quality, not more care, but right care. And so that's actually forced our hospitals to start doing what I've described already. Now, it isn't including the genomic markers for most, but it certainly is including the combination of problems and meds and labs and some aspects of cost as well. So an ACO has to have this data to survive. So I would say a limited part of this vision within 2 years. Genome maybe a little bit longer. I mean, there will be, of course, novel services that become available on the internet, and so maybe a private industry accelerator will help. But this is not a 10-year dream.
Perfect. Dr. Madison?
Yeah, so I'm going to, first of all, agree with most of what John says, but I'm going to try and find something to disagree with. No, I'm going to find something to disagree with. Don't worry.
And you got to wear black.
But one of the comments you made is about, is big data 3 terabytes? I don't know. What is big data? Petabytes, okay. So about 8 months ago, there was a survey done of 40 experts on data analytics about what is big data, what's your definition of big data? And they were all over the map, and there was 1 or 2 of them that resembled the truth. Big data is fundamentally very different than anything we've done before in that it relies on how you represent the data as atomic level data with atomic level metadata that helps define the data in situ, if you will, without having to have an overbearing data model, database schema, or ontology. And that is the fundamental difference of big data. It's not the volume, velocity, or variety that is frequently quoted as the essence of big data. It is the way the data is represented, and that's what MapReduce and Hadoop do, fundamentally different than all preceding databases. And so why does that matter? It matters a lot because getting data analysts to convert from the old world to the new world, and they're complementary, they're not competitive, they're very complementary, is an extraordinary chore. So I think that the first thing to realize is that in the world of big data, it's really an extraordinary environment to generate hypotheses, to look at data, to find outlier associations, and say, wow, is that real or is that spurious? And then begin to apply that. And so I found a place to disagree right here already.
Good.
So looking for what happened with the 10,000 patients that resemble your life is best done on a pre-big data environment where you have fairly reproducible relationships between the data elements. And I don't want to geek out for this whole response, but I do want to say that big data is really good for generating hypotheses, but the conventional world of relational databases is going to be invaluable to answer the kind of question. And Stanford published the first paper on this about 3 years ago in the New England Journal of Medicine. Basically, a teenager with a autoimmune disorder and renal failure and a question of anticoagulation, and they couldn't find anything in the literature, so they went to their own database and found a couple of patients that resembled that patient and came up with what looked like it would work based upon experience. But to John's point, where I strongly agree, is this is done at the level of Stanford's database, not at a combined UCSF Stanford database, not at a national database, not an international database. Doing these studies is virtually impossible today across institutions. The one model that I really favor and I participated in is called Scanner. It's started by Lucilla Ono Machado, who's the editor-in-chief of the Journal of American Medical Informatics Association. And what it does is it allows you to structure queries that can be transformed and applied in different institutions. Harvard is one of the participating institutions. So you can ask those kinds of questions in different institutions with different data representations in the old model and come up with a cohort of patients that resemble John's wife and to begin to answer that question. The second thing that was notable about your wife's situation is that there is today still no standard representation of the following, and cancer is fundamentally a disease of the genome. It is unique in that respect, and is the archetypal case for the application of genomics because it is fundamentally related to mutations in the somatic cell line that are related to mutations that exist in the germ cell line. And the combination of those gets very, very complicated. And if you've seen one woman with breast cancer, you've seen one woman with breast cancer, because the permutations of the genomics are vast. The combinatorial explosion of permutations is huge. So what's really needed is the ability to express the following. This physical representation of this disease has this association with this genotype. And to be able to say, John's wife has this physical manifestation that has this association with the genotype of that cancer. And by the way, cancers are almost all polyclonal at some point in their evolution, meaning that they're not all the same mutations. And so treating them as a single disease in a single individual is actually problematic. So knowing how many people might resemble John's wife in India, Africa, the EU, and Asia, as well as North and South America, is going to yield a small cohort that is better constrained to resemble his wife and give us a much better answer as to what actually works in people just like her, not people who have breast cancer, but people who resemble the genomics of the exact breast cancer she has. So I actually chair the Global Alliance for Genomics and Health. It's an international consortium. The work group on eHealth Phenome Genome to try and get at how we represent that and how we embody that in applications so that we can do these kind of queries across not just the US, but across internationally, because of the combinatorial explosion of permutations of genome and disease manifestations. To get a cohort that really resembles John's wife is going to require more people than there are living in the US. And so we're having our next meeting in Leiden, the Netherlands, in June. And by that point in time, we will have a test case with breast cancer with Heidi Rehm, who's doing the BRCA work internationally, to answer exactly that kind of question. So there is progress being made today on that. And then the last thing I want to say is about incentives and economics and how it is that we get from here to there, and it's not policy, it is about the economics. And one of the most constraining elements in the US has to do with the privacy issues associated with genomes. So first of all, you can't de-identify a genome. It's the most identifying thing on the planet, bar none. So attempts to de-identify the genome are very, very challenged. So GINA, the Genomic Information Non-Discrimination Act, thank you, was set up to protect people against discrimination for health insurance based upon their genome. And it was great, and the people who wrote it were awesome. And they made one strategic decision at the outset, which was dead on, and that is, if we take on, again, economic incentives, if we take on health insurance and life insurance and disability insurance and long-term care insurance industries all at the same time, we will get creamed. So let's pick the most important one. It's healthcare. They went after it. They got it. It took them 12 and a half years, and they did it. And that's amazing. So at the recent workshop held on precision medicine hosted at the Institute of Medicine by the NIH, I asked the question, when are we going to circle back and deal with non-discrimination for life insurance, long-term care, and disability? And the answer was, oh my God, don't even bring it up, because it took us 12 and a half years just to get health insurance. The difference now is that there's large industries, Illumina, Pacific Biosciences, that make money off sequencing. There's Ahmed's company about interpreting sequences. And so there's an economic interest in allowing this precision medicine to proceed forward. And so I'm actually on a campaign to align those economic interests, to lobby the politicians to provide protection for those other three types of insurance that are critical to prevent harm from participating in this ability to query databases anywhere in the country and anywhere in the world, for that matter, to get exactly to the result that you portrayed. So we're technically very close to the implementation, because we will have that semantic of this physical finding has this type of association with this genome, so we can do those queries internationally. But until we can actually reassure those who volunteer their genome and their electronic health record to this learning health system that they won't be discriminated against for any of those four types of insurance, we're actually not giving informed consent to what people are participating in.
That's excellent, Dr. Madison. Could I ask you two follow-on questions? The first is, in what time frame do you think we might be able to answer the first question, whether it's breast cancer, on looking for like patients in similar cohorts, like genomes, like somatic mutations, and what treatment worked the best for them? Again, is it 5 years, 50 years? What's your best guess?
Oh, I think we're actually getting there with BRCA. Heidi's work with BRCA, the breast cancer genetic marker for risk of cancer and the implications for the type of cancer and the type of treatment that works best, that is our first test case for the Global Alliance for Genomics and Health, and Heidi's done just an extraordinary job. A lot of people working on it. So we will have actionable results for getting that kind of information about breast cancer this year.
Phenomenal. And how many patients do you think will have gone into that analysis?
Well, and here's the other interesting thing about policy that John brought up, is that the U.S. Patent Office, in all their infinite wisdom, granted Myriad Pharmaceuticals the ability to patent the BRCA sequences. And when the Supreme Court overturned it, I was in a hotel lobby at 7 a.m. on I think a Saturday morning when the Supreme Court released their judgment, stood up and cheered. And I'd filed an amicus along with an institution arguing in favor of overturning that patent, which it did. But that patent was the biggest obstruction to progress in the space that there was. So that was overturned. What did Myriad do? They reassured all their stockholders immediately, saying, oh, but we have all this data showing that this BRCA variant has this association with this phenotype, and we're not going to share that now that we've lost our patent for the genome. We're not going to share that with anybody. So you have to pay an extraordinary amount of money in order to have your BRCA tested by us so that our analytics are superior to any other analytics. And that's what Heidi Rehm and the Global Alliance for Genomics and Health is overcoming today, is that restriction on who has that information. So we're aggregating that information from all around the world, and we'll soon have a much larger data set than Myriad Pharmaceuticals to answer that kind of question. So that's I mean, in terms of quantitative parity, I don't know. Heidi knows the answer to that. I don't, but it's probably within our grasp in the next year.
Wonderful. Good. Awesome to know. Dr. Zeiger.
Ronnie, please.
Ronnie.
Not John. So I think that this is a crazy exciting time, and I think that the most exciting part of it is not the answers that we're getting closer to, but the questions that we're getting closer to. So John Halamka's story about his wife, I think is really telling, because we with essentially today or tomorrow's version of big data got to the point where the answer was 9 months of Taxol. But then the question was, well, why 9 months? And the answer was, I don't know, right? We don't have the data. And in today's model, we never will. That's not going to trigger 10 randomized controlled trials of 6 different amounts of Taxol. Those aren't the most important questions that we can answer with our precious time and human and other capital. So I have a challenge with kind of the mental model that we're bringing to this. I feel like what we're talking about, you used another phrase that I'll steal Ahmed earlier, which is one of the things that we need is a GPS. And I was thinking about this conversation yesterday, and I was driving, dangerous combination, and I saw my GPS. I happen to use Google Maps on my phone, and I saw that the model that the GPS assumes and that this analogy requires is that I tell my GPS my destination. And in that case, my destination was a canonical, location, a record locator, if you will. And for John's wife and the billions of other people that we want to do right by, the destination is actually very difficult to define. And so, but we're getting closer because I got to an intersection, or I was approaching an intersection in my car, my GPS said, turn left. Or you could turn right, but it'll take you 20 minutes longer. So that starts getting interesting because there the answer might be, the analogy might be, okay, so turn left, 9 months of Taxol. Or you could turn right and we could reduce the dose of Taxol, which probably means a lower risk of neuropathy, which is a big deal to you, and a less data-driven likelihood of recurrence, but might be worth a chance. And so I decided to turn left at that moment because I was more interested in getting to my destination than in going on a more pleasant road. So I had, the GPS couldn't tell me which my preference was. In fact, it couldn't even tell me which was more picturesque. I happen to know that from my experience. The next version of that GPS will have a more sophisticated decision tree to offer me, which is left for these sets of attributes and right for these sets of attributes. And then the position that we're going to be in all of a sudden is to be able to have discussions with each other, whether that's between John and his wife, or between clinician and patient and family, or between researchers who are arguing about what the next most important research priority is. So I hope I'm doing an elegant job of totally
Ronnie,
answering a different question.
No, but I think you make a good point. But I would argue that we can't just say there's an infinite number of subjective choices, because the reality is, even when you use a GPS or a Google Map, you can drag and drop, and it gives you a constrained set of choices, like 3 to 5.
Yeah.
So there may be one choice where you're interested only in, say, survival at any cost, right? Any side effects. And there may be another one where there's a 50% chance of having irreversible neuropathy that you want to have less than that probability. But what I'm saying is, I think it should be scientifically possible, and tell me if you agree or not, to create a constrained, reasonable set of choices where that trade-off is made.
I agree, and I think that those constrained choices are the context for a less constrained conversation. Because while we can map out my path in my car from point A to point B, which only has, say, order magnitude 10 theoretically reasonable routes on paved roads that are all less than 10 times the shortest distance, or some reasonably constrained path. When we're talking about something more nuanced, like the quality of our life in the context of this passion and this loved one and this upcoming graduation, there isn't going to be, we're going to keep on, even if we solve the Taxol problem, the next situation is again with the big data, which we will have available to us in 5 years, is going to put us in a position where we can all of a sudden have a much more thoughtful discussion about choices that matter to us, as opposed to what is the right answer.
So this is a question for all the panelists. Would you suggest? I mean, it seems to me that if we had, let's say, 5 to 10 reasonable trade-off choices, that not a million, because that's not.
Yeah.
It wouldn't the discussion of those 5 or 10 with the patient be the ideal role for
absolutely,
a human
absolutely.
physician?
And one of the kind of negative reactions I had to one version of this discussion is that so first of all, medical school is pathetic in terms of what it could and should be.
But we're not going to change the lecture series to pathetic.
No, not at all. No. This
Anti.
lecture series is perfectly named. What I want to make sure we don't fall into the trap of, something which I think is a trap, is thinking that the next generation of medical training should be fundamentally an informatics one. Clinicians and all the people around them absolutely need to become essentially informaticians, but they will continue to need to have an equally strong skill set they and the team which they work in, which is another discussion which I suspect is going to come up, they and the team that they work in will need to be able to facilitate conversations about decisions that this new data-rich world is giving us the opportunity to make.
So, in other words, the informatics enables the conversation, doesn't replace the conversation. Is that what
Absolutely.
you're trying to say? Got it. Dr. Mattis, I'm sorry.
I was going to say, to continue the GPS analogy, I am in the sandwich generation, and I am the care traffic controller for all of my family members, those above me and those below me. And my father died 2 years ago today. He had multiple sclerosis for 23 years. He had myelodysplastic syndrome and 3 heart attacks. He and I had a lot of discussions about preferences. And it's exactly this issue you're talking about. Would he like to be intubated and resuscitated? Would he like to live his life without certain elements of quality? Or would he rather have a quality life shorter in duration? And so when I went to the ICU about 2 years and 3 days ago, I talked to the cardiology fellow, and he said, "Do you know your father has an ejection fraction of 20%? And I talked to the pulmonary fellow, and he said, "You know he has an O2 sat on BiPAP of 88%? And I went to the renal fellow, and he said, "You know he has a creatinine of 3.5. So this was my version of big data, right? Everyone was giving me all of this data, but no one could tell me how my father was doing. And I had to overlay what were the outcomes my father desired, his path in life, which is really a continuum from cure to palliation to hospice, and then make the decision based on the objective data and its trajectory that actually hospice was best according to his wishes." So as Ronnie had said, I mean, this is very nuanced.
Yeah.
You know, how do you make a decision that I don't want to die in an ICU with tubes in every orifice? I would rather die comfortable, surrounded by family, and that is a win. That is not a compromise. I got to do that.
Thank you. Dr. Madison, did you have?
Yeah, so there's a classic illustration of this very problem that happens 1,000 times a day in exam rooms around the country. And it's a 45-year-old woman who comes in and is newly diagnosed with hypertension and diabetes. And the doctor says, "Well, we've got 3 options for what you can do. Here's the high risk, high value. You've really got to work your tail off to achieve these goals option. Here's the low risk of side effects, not quite as good outcomes, and you can still be a couch potato, and here's something in between those two." And the woman's answer is very easy. She says, "Well, my daughter's getting married in 3 months, and I want option 3, the easy option, right now. But as soon as I get the relatives out of town after my daughter's wedding, I want option 1. I want to go for broke, and I'm committed to do it, but I just don't have the capacity to do it right now." So that conversation goes on all the time today, but it's not very well supported by a fact basis. It's not very well supported by informatics. And so while I agree with Ronnie in the short term, clinicians need to have a much stronger informatics background. We're only a couple years away from where tools like what Ahmed is developing right now will be vastly superior to the informatician's mind to wrap their head around all this complex data and come up with those options. Those are going to be the options of treatment are going to be machine generated. The role of the physician is going to change from one of being an option generator and a data interpreter to one of recognizing the basis of how those options were constructed and then elucidating efficiently and compassionately and empathetically from the patient. What are your current, not what are your lifelong or cultural or familial, what are your current personal value sets for risk aversion, for the side effects, for how much effort you want to put into this, and for what implications there are for your daily activities, such as being able to remain an artist with fine motor control. And so I think the medical student and the medical school and the output of that, the physician of the future, is going to be a back to the future, that we're going to hide the complexity of the data within the analytics that generate the options, and then we can have back to the future of the country doctor of having an understanding and an empathy of each individual's personal situation about their values and their life context, to interpret them, and not to say, I think this is best for you at this point in time, to say, okay, now I understand what your values are. I have a pretty good fix on that. And it seems to me that if the choice is not already clear to you, it seems to me that this option is a good match for your set of values, the way that we've just discussed them. And we reintroduce compassion and empathy as the centerpiece of caring. And as William Osler so wisely put it 100 years ago almost, the secret to patient care is caring for the patient. And I think we're going to liberate physicians to a great extent from caring so much about the data to being able to care much more about the patient.
Thank you for that wonderful response. Dr. Irani, I'm sorry, I had a quick question. In what time frame do you think we could have this intelligent kind of data-driven roadmap where that could inform a conversation on choices that would be based on data in like patients as opposed to, expert opinion, people behind closed doors?
So I think technically it feels like we're going to be there in about 5 years, certainly less than 10. In terms of how soon it will happen, other than in very special situations like John or John's institution, depends on a combination of economics and politics. So for example, if I had to decide how this would all work, God forbid, I would say, look, all of the hospitals let's just be a little bit more generic, all of the health systems who want to be informed by big data which exists but they don't possess should be able to query John's system for a fee. And those who own the systems that have the data are most of which, for various market forces, are very worried about sharing something which is valuable, and so the way that asset, that increasingly valuable asset, is shared, I think is probably going to be done on a syndicated basis, as opposed to on a let's send a copy of everything to the next system that will be hacked. And the economics, that's the politics of it. The economics of it, I think, could double that time frame as the economics are worked out. I think entities are gonna hoard their data and pretend that that's in their interest because they can get more patients referred to them, but really it's a waiting game.
Thank you. Let me ask you a question for all the panelists. Let's suppose that there is a very progressive country that is not burdened by all the regulations that we have here, and they decide that they're going to, they already have a national health system with a centralized medical record, and they're going to, for example, and they decide that when the sequencing hits $300, everybody's going to get it for free at birth. And so now you've got they have a database of 20, 30 million people with sequences on everybody, and they can develop this kind of knowledge, this GPS and roadmaps. And they're not being burdened by regulations or anything like that, and they can just start publishing it to the world. How do we compete against that?
Well, that's the beauty of the flatter world, right? So we'll start losing that competition, and many people in this room who are relatively well resourced will start putting legs under the burgeoning industry of medical tourism, and then Congress people's spouses will say, WTF. I forget what that stands for.
How convenient.
and we'll say, so then we will get cultural pressure, which will eventually overcome whatever barriers we have to doing that properly ourselves.
So that'd be a good example of Grove's Law, right? Now, hopefully it'll be done in the United States, but, we have to be, concerned. Dr. Madison?
So I'd like to sort of key off of that with what may appear like a digression, but Obama has named the initiative for the NIH, I think, precision medicine as opposed to personalized medicine. I think it's really important to observe that identical twins have never had identical outcomes because the interplay of the genome with the environment and behavior is so profound and so impactful on health outcomes. So if identical twins don't have the same health outcomes, how can we possibly apply the term precision to genomics. So first of all, my perspective is that genomics is just barely the keyhole to open the door. But behind that door is proteomics and metabolomics and all of behavioral sciences that really determine which of the twins gets hypertension, which of the twins gets diabetes. And this applies across the whole range of diseases. Schizophrenia has, I think, a 51% concordance in monozygotic twins and like 5% in dizygotic twins. So we know that the genome is influential, but it's far from the whole story. And so as we get into personalized medicine, we're going to realize that precision is a very elusive goal and probably a terrible misnomer and misrepresentation of where we're headed. But I do think that creating better incentives for sharing data is going to be critical. And as I mentioned earlier, better protections for the sharing of data is going to be critical. But until there is an economic and a policy framework that enable that, the data sharing itself is going to be challenged. As to Ronnie's point about whether you have a big database in the sky or whether you have a federated data system, I just proposed to the Global Alliance for Genomics and Health that we write a white paper looking at, there's a spectrum between fully centralized and fully federated data where everybody keeps their data and you operate on it in a distributed fashion. And there's a spectrum of use cases that determine which one is appropriate. And there isn't a right answer for how to do that. There is no right answer. It's use case specific. And let me give some examples. There are some very severe pediatric diseases, thousands of them, that are genetically related. The parents of those children have already donated everything they've got about their kid, because the sooner that we understand the disease and get to a treatment, the better the prospects of their kid surviving their 10th birthday or their 20th birthday and living a more healthy life. So the motivations based upon an impactful genetic disease in childhood are such that and because it's rare, a centralized database makes perfect sense. For other use cases, like breast, common disease, so-called common diseases, there's no such thing as a common disease. There's just an aggregation of uncommon permutations into a phenotypic expression. That a more federated approach makes sense. And then there's everything in between. So there isn't a right answer to the question of centralized versus federated, but a spectrum that we have to parse out to specific use cases. And more important, from my perspective, is what John was saying earlier about having the right economic incentives in place, and what I was saying about having the right protections in place. So once we get the right economic incentives for sharing data and the right protections in place, I think there will be a true proliferation, because it will be unconscionable not to share data for the benefit of others.
That's a great lead-in.
And so a quick follow-on to that.
Sorry,
I'll be quick, I
please.
promise.
No problem.
Here's the challenge we have. So I'm in Washington about a day a week, and so you recognize we actually have 56 different states because we have territories and states, and therefore we have 56 different sets of privacy laws. And in Massachusetts, where I'm from, we actually think opioid addiction is bad. And so when John comes to see me in the emergency room and says, I have back pain, never had it before, but I think Demerol 125 milligrams IM times 3 will probably cure it, I want to be able to look into a database and say, this is the 11th emergency department visit you've had this week. It's probably bad to give you opioids. In New Hampshire, it is illegal for the state government to aggregate opioid prescription information. You can also ride a motorcycle without a helmet, and you don't have to wear a seatbelt, which is why the license plate says live free and die.
Live free and then you die.
Ah, well, but anyway. So what is the secret to getting beyond all this bureaucratic restriction? Volunteerism. And what do I mean by that? So can we have a national healthcare identifier that allows us to commingle all our medical records in a central or federated way? Well, Bill Clinton signed an executive order making the national healthcare identifier discussion illegal. And so, our friends at HHS can't even talk about it. However, I have chosen to give up my privacy in many ways. This is my global entry card, and I signed up for this so that whenever I come into the United States, I have given the government my biometric identifiers and my demographic data, so I go from my seat to my car in 2 minutes. It is convenient and easy for me. I was the second human sequenced in the Human Genome Project. I agreed to give up my privacy for my life. My genome is public, my phenotype is public, my lab, everything about me is public. In fact, my bathroom scale is connected to the website, so every morning when I weigh myself, it's public data. It's a little bit weird.
But there is no webcam in your bathroom, right?
No.
Just making sure.
And why did I do that? Because I felt the benefit to me of having my genome and my medical record available to all potential caregivers and science would actually outweigh any risks. And this was pre-GINA, right? So I actually had no protections of employment and insurance or anything like that. I made that decision. So if we all use ResearchKit or whatever software system and can contribute our data, I think that's going to be faster than waiting for bureaucratic resolution of 56 different states and territory laws.
Beautiful. Thank you. That leads us to the next question, which is, how do we think the human genome will be used in routine clinical care? And again, the key word here is routine. And I wanted to start, I think we'll go in the opposite order since Dr. Halamka just spoke. So Ronnie, how do you think it will be used routinely, and what's the workflow? And will it just be that everybody's sequenced at birth and it's always available, or can you give me some ideas how it will reach the bedside? Because at the present moment, 95% of sequencing is for research purposes, just for a little bit of a background. There was only a reimbursement code for a whole genome sequence approximately 12 months ago, right? So we're talking about, we're at the cusp here, but is that translation 5 years, a decade, 20 years? Ronnie, what do you think?
So I think it's, I think we're going to have a steady, modest flow of this increasing by use case. So it's not I'm going to have to break down your question into A through M.
So what do you think the top three?
But I'm only
going to
go through A and B.
Okay, our top two use cases.
So I think use case number one, which is already in almost routine practice, is targeted therapy in oncology. So it's actually scary how unroutine this still is, and how it very much depends where you're getting treated, even within an advanced, quote unquote, advanced country like ours here in the US. But in many cases, depending on which cancer you have, it is approaching malpractice to not know certain genotypic aspects of your tumor. And so we're getting towards routine care of genomics being part of the routine, basically a routine test that's part of your staging.
And when do you think that transition will occur to
3 years.
where it's malpractice not to sequence
3 years.
for oncology?
Yes.
Okay, perfect. What about use case B?
And use case B, I think, is going to occur much more gradually, but is similarly starting to permeate into some of the nerdier corners of clinical practice, and that is pharmacogenomics, which is how different mutations predict how you will respond to various medicines, which can include, one of the popularly known ones is I don't remember the mutation, but it's a straightforward genetic test which would tell you whether or not codeine provides you with pain control or simply feeling a little bit goofy. And I think it's on the order of 20-ish% of people who don't benefit much from codeine, and today we figure that out by prescribing codeine, and then we may find out from the patient that it didn't really work, and then we try something else like hydrocodone. So in anticipating response to things that we do very routinely is where I think it's going to start. And as those things become part of the mainstream, it'll give us an opportunity to learn about workflow and reimbursement and cultural issues and actual and perceived fear of discrimination, which will in turn hopefully let us be ready for the science of this becoming.
So
you know,
oncology and pharmacogenomics. I just add an interesting data point, 2 data points. First is that 20% of all new drugs today have an FDA genome label. So for example, there's a sequence or criteria that's required, and it's growing very fast. And it's almost unmanageable to keep up with this. There are 1,300 sequences that can be used for a cystic fibrosis drug, and last year there were probably 800. So it keeps growing. The other interesting observation is that there are studies that show that 25 to 35% of patients are known non-responders to medications if the molecular data were known. So think about that. Potentially a quarter of people are going to get a treatment that we could know won't work. So it's an interesting data point, and that knowledge base will keep growing. Dr. Madison, what do you think are the top 2 use cases, and in what time frame for the use of genomics as a standard of care rather than just an interesting, oddity?
Yeah, I'll answer the first question with a shout out to one of the faculty here at UCSF, Laura Esserman, is on the bleeding edge of a paradigm shift in oncology, and I don't know if she's in the audience. But what Laura has pointed out is that because most cancers are polyclonal at some point in their evolution, many of them day one detection, that the current model of testing new cancer therapies with metastatic disease is a fool's errand. Because when you've got 10, 12 clones and you introduce a new drug which might have cured that individual early on, but which completely annihilates one of 12 clones at a metastatic phase, you judge that therapy to be ineffective, and it's a no-go for that drug for, say, breast cancer, when in fact new drugs should be tried much earlier in cancer evolution, so that when they're less polyclonal, we can actually see the benefits of the agent vis-a-vis the genetic subclone. So there's an implication not just for when it's malpractice to treat to have that information, but there's an implication for malpractice in how we test new agents for many types of cancer. So for the second half of the question around, when will this really become an absolute reality? I would say that outside of cancer, which is fundamentally a disease of genomics, that genomics itself is going to be, as I said before, the keyhole to the door, and the door opens up into metabolomics and proteomics and other omics, and because identical twins have different outcomes, what we're going to be doing is we're going to be sequencing people and say, based upon your genome, outside of the cancer domain, you are at a higher risk of these 17 diseases and lower risk of these 17 diseases. But we now know the proteomic metabolomic markers of those diseases. So rather than just say, you're at high risk of these 17 disorders, have a nice day, which is not exactly a very therapeutic intervention, we'll be able to say, and we know what to measure to detect the early evolution so that we can intervene earlier. And what's going to happen in this world of big data science, in this world of combining data from multiple sources, your genome, your phenome, your proteome, your metabolome, your behavioral environment, all the wearable sensors, is that we are going to be fundamentally changing the sensitivity and specificities that we call out as thresholds for action. And by that, what I mean is, just imagine if we have a bot that's implanted or transdermal that senses a genetic permutation that reveals the new onset of breast cancer. And we've already got something like that for epithelial cells for an imminent heart attack. But imagine that we have these kind of sensors that we can put into your body. We're probably going to be finding cancer cells in every one of us every day, which our immune system non-ceremoniously just eliminates. And so our ability to have very, very high sensitivity for some of these diseases is going to and this is not the first time it's happened in the history of medicine, as we discover a new disease and then expand the scope of impact and the severity of the disease, we change the sensitivity and specificity for threshold for intervention. We are going to find that we're going to have to recalculate the whole science of what reaches threshold for sensitivity and specificity of the data that we have based upon the type of information that's available to us, never before available. So I think we're going to end up with the genome helping us understand what in the proteome and the metabolome and some of the other omics we should be looking for in each individual as a monitor, because the somatic line genome is stable throughout our life. I'm sorry, the germ line is stable. The somatic mutates for cancer, but to the extent that non-cancerous diseases can be monitored in the proteome and the metabolome, I think that's probably 8 or 9 years out. I'm not optimistic about the genome being helpful outside of cancer and some uncommon genetic disorders, but it's more than the metabolome and the proteome.
So 8 or 9 years out for what I think you're calling is a continuous liquid molecular biopsy, so to speak. Yeah. So it's.
So let me argue with it about it. And Mark, you may find that this is actually, because it's a cancer example, not true. But so my genome, right? So I've known it for several years. My 3 billion base pairs, and it's all public data. So hundreds of doctors every day look at it and decide what I'm going to die of next. One of the things they have published is that I am twice as likely as the average male to develop prostate cancer. Now, my primary care physician, who it's very, very early days, but knows the biomarkers in my genome and looks their probability and their risk, they said, well, the New England Journal of Medicine says PSA is a bad test. You know, we've spent billions of dollars on PSAs, haven't affected morbidity and mortality of prostate cancer, so stop ordering them on a routine basis. Right. But he looks at my relative risk and says, oh, well, your genome suggests you have twice as likely a relative risk of dying of prostate cancer. Why don't I order a PSA on you, even though the New England Journal says over the population it's not that relevant? Similarly, my genome indicates, and my lab tests indicate, and I recognize this is environmental too, that my risk of heart disease and stroke is extremely low. And I'm vegan, so I have no exogenous source of cholesterol. So every year he's ordering cholesterol, triglycerides, LDLs, and all the rest. My total cholesterol is 72. What's the point? So for you, forget all those cholesterol, triglyceride panels because of your environment and your genome, but PSA, yes. That's being done today. To your point, we don't represent in the medical record these biomarkers in a logical way, so we're a couple of years away because you're going to solve that problem. But I'm actually, optimistic that you're going to start to see clinical judgment change based on biomarkers within the next couple of years.
That's a beautiful answer. I actually wanted to add a little bit of color as an anesthesiologist, and I wanted your opinion on this. So, I've seen 3 operating type of catastrophes in my career as an anesthesiologist. One is mismatch of tissue typing and transplantation, where there was no reconciliation of the donor with the recipient. Second is the first discovery of massive bleeding disorder on an operating room table, because a lot of people that have subclinical bleeding, they brush their teeth, they have a little more blood, but then they have a catastrophe the first time they have an operation, and it's usually a C-section that unveils that. And the third is the inability blood clotting factors, inability to know which anesthetics can be safely given. So, for example, there's succinylcholine is a paralytic that normally lasts 10 minutes. If you have a certain deficiency that's very common, it can last weeks, and you can be paralyzed for weeks, right? So, and if you're not on a ventilator the whole time, you won't make it, right? So, to me, all 3 of those are precisely determinable through a single genome sequence without any fuzziness. It's not like a 17% higher chance of getting, hypertension. It's very precisely determinable. The reason I believe that's not the standard of care today is it's still thousands of dollars per genome. At what price point do you think it's too cheap to not be the standard of care? Does that make sense? Does that question make sense? So, Ronnie.
Before making up an answer for you, I'm gonna suggest that part of the answer will be determined by informed consent. So I suspect that we do a lousy job of, so you just enumerated 3 rare but potentially important issues. If we did a better job of consenting people pre-op about those possibilities and gave them the opportunity to pay out of pocket if they wanted to decrease the chances of that, we would A, learn a lot, and B, be shamed into figuring out what the real price point should be and what we have to do to the science to make it more affordable and figure out who should be paying for it. Because right now, I can't really answer that question. I'll make up an answer for you in a second. But because, I don't know, we haven't really talked about it. We don't have a cultural understanding of what that means.
The reason I brought up price, though, is because
Yeah.
a lot of things that become a standard are not realistically, they won't be published as a standard because if they're too expensive, right? But if something's $100 and it could guarantee to identify a problem, shouldn't that be a standard? I mean,
so I'd say sub $1,000
okay,
for that panel.
right. Dr. Mattis?
So at JP Morgan conference here in the city last year, Illumina announced the first $1,000 genome. That was price, not cost. That was,
Right.
I mean, cost, not price. That was the cost to do the sequence. It hasn't really budged much in the last year. So for the first year in history, the exponential decline in the cost of sequencing a human genome has kind of got stuck. And it's not clear what's going to break that logjam. But when it breaks with a new technologic approach, it's probably going to drop in the $200 to $300 range. And that could be in a month, that could be in a year, no one really knows, because the first genome was billions of dollars, the second was billions of dollars, and today it's $1,000 at the cost, not the price. So I think that we're actually not starved by the price point yet, because our ability to you listed some great examples.
So why is it not standard care? Lack of education?
Well, 1,000 cost is still too high, so the price is up.
But if it was
significantly upwards, if it were
$5, would it be the standard of care?
if it were 200, I think it would be the standard.
That's the number I was looking for. Your opinion.
He tricked you into giving a number.
So let me actually give a slightly contrarian view, which is, in my genome, I have 6 genes that predispose me to glaucoma. Now, I know this is going to sound very strange, but because I'm a physician, I don't do any preventative care. I actually went to an ophthalmologist who measured my intraocular pressures, 26 in each eye. Surprise, I have glaucoma. Now, I asked my father, have you had any eye problems? He said, you mean the glaucoma? So I had to get my genome sequence to find my family history. Right. But if you ask, okay, fine. They told me it was millions, not billions. But let's say it's $1,000, and in an ACO environment where you're paid for wellness, not sickness, if $1,000 prevents you from going blind, what is the life cost of treating blindness versus a sequence of $1,000? I think the ACOs will be incented to do this.
But at what price point do you see there being an exponential adoption? Is it a price problem, or is it a physician education problem? What's keeping us from having exponential adoption?
So it's alignment of incentives. That if it's an ACO, $1,000 may be fine. If it's out of pocket, it may be $200. The question, of course, is what's your personal benefit? So what if, I get a safe driving discount? What if I got a safe eating discount or a safe healthcare discount on my insurance that would make me incented to go for this test?
So just for the audience, there's some interesting papers that are coming out now within the last 6 months showing that in diagnostic dilemmas in children that the whole genome sequencing is finding diagnosis 25% of the time that were previously unresolvable. So I think that it's going to, in my opinion, it's going to get pretty compelling pretty quick. I just wanted to know, if you think there's a magical price point.
Well, let me give you this is a non-genomic example, but it illustrates the point. So with my $1.2 billion of global capitated risk, that is patients who are going to, get reimbursed based on their wellness and their outcomes as opposed to their fee-for-service costs, we had a COPD patient who came into our emergency department every summer when it was hot and humid in Boston, $35,000 of medical care consumed every single summer. Well, now that we're in an ACO, we bought him an air conditioner. $350 at Home Depot. He hasn't been to the hospital this year.
Wow.
So we were perfectly incented to spend $35,000 a year, and now we were willing to spend $350.
Interesting.
So you see, it's not quite 200. $350 was good.
Good. So we have about half an hour left. What I wanted to do is about 10 more minutes on questions and then open up for the audience and, of course, for Professor Grove. So the next question is, will crowdsourcing of knowledge prominently manifest in the doctor-patient relationship? So what I mean by that, and again, I think we're thinking only about, EMR data and payer data, but what about all the patient self-reported data? And Ronnie, I know you're, in the thick of this in your day-to-day activities. Can you give me an idea of how important it will be and how will it manifest? And I mean, will patients bring printouts to the doctor, or will doctors consult databases? The crowdsourced aspect of community.
So I'll start by sharing that my comment earlier about the unequal distribution in this country of the degree to which people with cancers, with certain cancers who do versus don't get genetic testing ahead of their treatment decisions. So I've been hanging out with online patient communities for the last several years. That's my day job, in particular in the oncology space. And I have a non-random but lots of anecdotal examples now of seeing information flow from academic centers to patients at academic centers, to patients not at academic centers, to oncologists not at academic centers. So this is sort of the most interesting and underground CME system I'm aware of, including much of the time where the clinician being educated doesn't know how it's happening, because a lot of the conversations among patients also include, here's how you explain this with your doc without making them feel dumb. And so this is...
Very important point.
Yeah, don't make us feel dumb. And so I want to make a distinction between crowdsourcing and what I kind of clumsily refer to as networks of micro-experts. So the canonical crowdsourcing example is like you go to the county fair and there's the farmer who's selling a bull and the bull is on the stage, and someone noticed like 100 years ago that if you polled the audience, all the uneducated farmers, how much do you think that bull weighs? The mean of their answers is remarkably close to accurate, to correct, which is very different from you join an online community of kidney cancer patients and you ask a question about the radiation therapy that you've just been suggested, and it's a certain 20 people of the 800 people in the kidney cancer community who happen to have learned about the role of radiation therapy in kidney cancer, either because they or their loved one experienced it, or because they happen to just be at a conference, because a lot of patients actually go to conferences and pay the registration fees to learn, and then they write to their friends about what's going on. But it's a certain subset of the network which contributes and leads that conversation, whereas if the question is a different one, it's a different subset of the network. And so what I think is happening first in the patient world, and it will come to the clinician world, is that we're learning how to practice, how to share more collaboratively, how to practice medicine, if you will, as a team. So I think that, I gave an example in a previous talk, in a talk that I gave a while back, that what I wanted to do one time that I was hospitalized and frustrated with the quality of care I was being given, in my perception, not at UCSF. It was another institution I won't name. It rhymes with Schmamford, and where I also trained. And I realized in retrospect, at the time, there wasn't even Wi-Fi in the building. But I realized in retrospect, reflecting on it, what I wished I had been able to do is tweet what was going on and ask my community what they thought. And I happen to have an unusual crowd that follows me on Twitter, so this wouldn't necessarily be useful for everyone, but I have a lot of people who I know would give me really useful feedback. And so it comes back to the very first question, which is, this data-rich world that we're just beginning to get our heads around is going to allow us to ask smarter questions and harder questions, and it's no longer going to be good enough for the answer to come from one person, expert or otherwise, and we're going to have to be able to collaborate quickly, whether it's this collaborative that we happen to be have ad hoc created right here, or other ones that are more explicitly created. Today, I happen to live in a world where there's a lot of crowdsourcing or networking going on among patients, and it's transformative, and we're only beginning to see what that means. One of the ways in which it's going to be transformative is that I think the other parts of the healthcare system, besides just the patients with the patients, are going to learn to collaborate more real time.
Excellent. How do you see this manifesting, though, at the bedside? In other words, do you think the doctors will consult data online during the patient encounter, or do you think they'll prepare better before what's the workflow that you see?
So I'm not yet normal in this way, or I'm not normal in many ways. So let me tell you something that I do, which I realize isn't common. I'm seeing a patient. A question comes up, which I don't know the answer to, but I think we could probably find online. We look for it online together. And part of that is a philosophical point. Mm-hmm. Patients will increasingly come not just with a sort of the now stereotypical and outdated printout from the Mayo Clinic or WebMD or whatever, but will come with thoughtful arguments from networks that they're a part of.
I see.
And then what will happen is that we doctors will say, oh crap, I can't compete with this. This is like a really thoughtful set of, basically there's a dozen really good medical librarians who have done research for this patient, and I need to help them sort through this, and I now need to go and do research, but I don't have time to do this for everyone. So how does that become more collaborative? So I think there's going to be a lot more of these kinds of there's going to be a lot more pre-visit planning, mm-hmm. And a lot more team-based approach that's required so that I, as a clinician, can tap into the network of micro-experts that I have at my disposal, instead of just saying either, well, I think I know, so let's do it, or I think I don't know, so let's refer you.
Yeah, Dr. Madison, do you think it's possible to have the ability to query into crowdsourced, patient-generated knowledge at the point of care? Is that practical? Do you agree with Ronnie?
So I'm a big fan of crowdsourcing, and
well, I was thinking about workflow also.
Unlike most people in my gender, I love asking people for directions along the way. So that's a gender-specific behavior, and I'm a deviant on that one. But I think crowdsourcing is phenomenally powerful for the right question. I want to inject two other concepts to kind of inform the question itself. So one is something called positive deviance, and the other is something called open notes. So positive deviance, those of you that haven't read about it should Google it. But basically, it's looking for communities or individuals that achieve superior outcomes and studying the heck out of them so that you might be able to generalize it. And a friend of mine is actually experimenting with this, a positive deviance among patients. He's looking at people with a particular diagnosis who just do much better than all of their peers, and engaging them both to find out what it is they're doing and to use them as a mentor and a coach for other people with that same illness, because they have found a path to succeed, whether that's through crowdsourcing from micro-experts or from doing their own research or from developing behavior tools that work for them. But there's a real potential for a combination of crowdsourcing and positive deviance as complementary inputs. The second thing is open notes. So just show how many people heard of open notes, know what that is? Okay, just a couple of folks. So Tom Del Banco and some other folks at Beth Israel in Boston have pioneered this notion of the minute I sign my note on you as a patient, it goes to my chart and it goes to your chart. And you have access to everything. And physicians are railing against this en masse because they're fearful that this is going to generate all kinds of questions. Well, what happens when people get their progress note from their doctor at the same time it files a medical record, and they see all kinds of terms they don't understand? They go to Google, they go to their crowdsourced network, they research it, they crowdsource it. They are a far better informed and engaged patient. When they come back the next time and the physician uses that same arcane medical jargon, they actually know what it means this time because they've seen it in writing in the progress note, and they've Googled it and they've crowdsourced it.
And they've corrected a couple of errors in the record.
Oh, hopefully many errors. Your medical record is full of errors, trust me. It's because nobody has the interest in you're having an accurate medical record more than you do. And so if you don't have access to your digital record, demand it, because you should. But I think a combination of crowdsourcing both with peers as well as with experts as well as with researchers and positive deviance and the ability to have access to your information through open notes is going to be a symphony of change that's really going to change the way that there is this collaboration and dialogue. The last thing I want to mention is I think there's three fundamental conversations, and this is what I've been building towards for a long time and supporting through systems, and I mentioned earlier that I think the machine is going to generate the options and the human is going to broker the application of the value set and the objectives to those options. But there are three fundamental conversations. One is between the patient and their care delivery team, a collaborative team. One is between the patient and their personal care team, whether that's using Ronnie's application for crowdsourcing on the web, or whether it's their friends and family, or some combination thereof. And the third conversation is between that patient and the person that actually houses the patient persona. So how many of you have had an elderly relative come home from the doctor? You say, what'd the doctor say, Mom or Grandma? And the answer is, oh my God, I was so nervous I don't remember. Well, imagine now that they've got their full medical record, including open notes, from that day, right in front of them, full access to the information. And so when they're not anxious in the doctor's office, hearing jargon and bad news, they can actually look at their medical context as a patient from the perspective of the whole person and begin to make some rational decisions. So what I see happening is using all these new technologies to construct visualization of the kind of options that are available, and then using those visualizations, which are very accessible, not just to the patient, but to the doctor and the personal care team, to actually have the kinds of conversations that will really result in a transformation of those options into a value-based set of
And in what time frame, that's a very insightful, what time frame do you think these kinds of options will manifest?
I'm working with some startups that are working on all this today, so probably, there's, as William Gibson famously said, the future's already here, it's just unevenly distributed. And so there are pieces of what I'm describing that exist. Every single aspect that I'm describing exists in some form somewhere. Putting it all together, integration, diffusion, scaling, and the motivational aspects of it are still lacking, but there's nothing I described that doesn't exist in some form today.
So since we have an engineering crowd here, is it just uneven distribution, normal, Poisson? What's the distribution?
I'm sorry, the distribution of what?
The unevenly distributed future, what kind of distribution is it, do you think? Is it Poisson? Is it
I've
normal?
never been asked Alan before. I don't think it's Poisson.
Ronnie, what do you think?
It's pretty haphazard. In statistical terms, I
Haphazard.
think it's haphazard.
It's not let me quickly describe some of the things we're doing with patient
Yeah, absolutely.
data
Sorry.
and how we'll see dissemination of innovation.
Yeah, absolutely.
So again, personal example. So my father's treatment for multiple sclerosis during the last 10 years of his life included every bioengineered drug that is coming out of Biogen, Genentech, and all the rest. And for those who may have family members with multiple sclerosis, you may know the side effects of these drugs is sometimes worse than the disease. But there's no way to measure them because we don't actually ask the patient. So we gave you Avonex. How you feeling today? What's your mood? What's your flexibility? What's your pain score, etc.? So my father, I didn't know he was doing this. In the 24 hours before each of my visits to his home, drank Solumedrol. Now, for those of you who know, Solumedrol is an injectable. It is not an oral medication, but what he found was it masked all the side effects and symptoms of all the bioengineered drugs he was taking. So, okay, I arrived. We went for nice walks. He was in a great mood. He had great flexibility. If I would have had the patient-generated healthcare data, what I would have seen is that 361 days a year, he was moving 50 feet a day. But 4 days a year, he was moving 5,000 feet a day. And so, imagine he was carrying an iPhone, and, we all now have on our iPhone things like this that show our activity and these sorts of things. And this was submitted to either the care traffic controller or a primary care physician. And you're like, that's pretty weird. And then you could make an intervention. So what Beth Israel Deaconess chose to do as sort of follow on to Open Notes, we've done two things. We've created an app called BIDMC at Home where you, the patient, consent to share the data gathered about you from your phone, and that could be movement data, but it also could be your bathroom scale, blood pressure cuff, pulse oximetry, and it goes back into the shared medical record. Like you, we don't have an EHR and a PHR. We have a shared medical record across the care team and the patient, so you can now have that benefit of all the data you can't get from a doctor's visit. Similarly, we are having the patients author notes. So nothing about you without you. Here's the note we wrote today, but now you write your version of the note because there's a lot of correction and interpretation that is made in that context. We are finding malpractice assertions are going down, and value-based care, the goal-oriented outcomes you want to achieve, are now being better considered. And this is happening today. Apple Watch coming soon.
And you named that project Our Notes, complementary to Open Notes.
Right.
And so if you want to Google what he's talking about, it's called Our Notes, and it's awesome, and it should be the standard of care today, and it's not yet.
Thank you. I had a quick question. We have about 20 minutes left, 15 minutes. How many people have heard of, along the line of the concept of crowdsourcing of knowledge, how many people have heard of the gene CCR2? Can you show hands? So CCR2 is a gene that confers resistance to HIV. So patients that have that gene don't need medications, they don't get HIV. There's another example of a boy who's a circus performer in Pakistan, who I think was found on Facebook or something, who is able to, he puts sharp utensils through his skin because he feels no pain. And he has a family that's like this, right? So the question is, can you imagine if we can find the molecular basis for that? Think of how many patients there are with cancer pain, right? And the current pain medications as an anesthesiologist all have horrendous side effects, right? They make you stop breathing, they make you vomit, you can't have a bowel movement. So this crowdsourcing can reveal these patients that I believe that we talked about that would never have probably been found otherwise, or may have been relegated just to be a circus performer the rest of their life. So that's just an interesting closing point that I believe we believe. I think the crowdsourcing is definitely going to work, and I think it's going to happen faster within 5 years. Would you guys agree? Mm-hmm. And so thank you for attending. This is a wrap, but we'd like to leave the floor open for questions, and thank you for attending.
Sort of two really quick questions. First, I sat on the EHR Association Executive Committee for about a year and a half, and so we were, educated about the FDA rules, FDASIA rules, about how this technology can potentially be classified as a medical device, which subjects these vendors to taxation and sort of limitations on how they can market the technologies particularly to physicians. Wondering what you think about opportunities for lobbying to kind of open that up so that there aren't barriers to innovation. And the second sort of comment/question is, we've learned from a lot of randomized controlled studies where we had moved from the kind of what a lot of people call sort of eminence-based medicine, trust me, I'm a doctor, I trained at UCSF, MGH, that's why you should believe what I have to say, to these randomized trials where we compared control therapies to novel therapies, and we said that the novel therapy confers some statistical benefit. But the reality is that there are patients in both the control and the treatment groups who actually do better on the control therapy. And so instead of relegating everybody to the new therapy, we should potentially go back and remind those studies, and maybe we'll find that there are specific genetic predictors for the patient who actually does better with a mastectomy than breast conservation, who does better with the Taxol than with AC alone. So I'm curious your thoughts, anybody on the panel, on those two issues.
I can start with Fidesia if you want.
Go ahead.
Okay, so the Food and Drug Administration Safety Innovation Act is a risk-based analysis that I thought actually is pretty reasonable. So example, if I write an app and that app says, you know, you're spending the evening with Ahmed, you're eating rich foods and you're not exercising, buddy, start moving. That's not going to be regulated, right? Because that's a wellness kind of app. Or something that reminds me to take a medication, that may be an administrative app. If on the other hand, I take a selfie and it says, you look pale today, it's probably stomach cancer. Well, that's going to be regulated. And so Bill Maisel and the guys at FDA, I thought did actually a fairly reasonable job of saying, go innovate on patient-generated healthcare data, go innovate on all these things that are going to make wellness, crowdsourcing, and all of Ronnie's cool stuff happen. And only when you make diagnostic or therapeutic decisions on behalf of the doctor do you seek regulation. So I think the FDA can be convinced that there's a low-risk, innovative application, and it will be unregulated.
So I'll answer it a couple of ways. Great question, by the way. So the first is the FDA is holding, a series of hearings on all this, and Congress is actually going to have hearings the end of this month on how to correlate the level of transparency with the level of regulation. So what they want to do is say, if you're really transparent about the algorithms you're using, it's open to everybody to review, it's self-healing, self-correcting through transparency, and so it's safer to allow decision support systems on the market that are fully transparent than it is those that are a black box. And so the question is, to what extent is industry willing to expose their algorithms and risk their IP for the benefit of not being FDA regulated? I want to second one of the things John's saying. The FDA knows that the regulatory process is broken. I mean, they're really, really interested in novel ideas and innovating how the FDA works. Unfortunately, the board of directors looks a lot like Congress, because it is Congress. And so getting anything to change in that board of directors is very, very difficult. But they're trying very hard. I mean, they really genuinely want to change things. The other thing I'll mention is to your question about some of the outliers did better with the control than with therapy. Well, you look at John Ioannidis' work about how I think 41% of all published medical literature is subsequently refuted, and much of the rest of it is never refuted because it's so obviously wrong. And so, no, it's fact. It's a fact. You look at published journal articles in referee journals with editorial boards, and there's just a lot of garbage that gets published that turns out to be harmful or just not helpful. And so, to your point, looking for those outliers, the positive deviance model is going to be very important. To your question about whether it may have been useful for a sub-cohort of the population, I think what we're going to see is we're going to be resurrecting drugs that were discarded long ago because, say, phenylbutazone, 1 out of 10,000 people get agranulocytosis. Well, if we know who they are genetically, we can release that drug back on the market, and it will have a niche for people that's very effective and more effective than other anti-inflammatory drugs, knowing that they're not going to get this idiosyncratic fatal side effect. So we're going to see microcohorting. Now, one of the major implications of microcohorting is, and the drug companies, Genentech included, I gave a talk at one of their conferences recently, they know that they need to have much more open collaboration between the pharmaceutical companies, because a $200 million cost of developing a new drug when you've got a micro cohort of people who will benefit from it is not a sustainable business model. So they're pretty freaked out about the implications of personalized medicine. It's just a fact that we're going to have far more drugs coming to market for far smaller populations. The economics of that are very, very challenging. So we're going to see a much more collaboration between the pharmas for precisely the reason you identify as we get more and more personalized and micro-segmented in cohorts.
Dr. I'm sorry, right, in the hat?
Okay. Yeah, so I'm a stage 4 cancer survivor who started a company called Beyond Spaghetti a couple of months after my cancer treatment. Apparently, 2013 is a published research paper, which is a summarization of 20, 30 research paper, shows creative arts therapy, which huge prize means like dance, but also art and theater, improving quality of life for cancer patients by 50%, reducing pain by 59%. So right now what we have, my background before cancer was mostly in internet technology. So we have is a web RTC platform, enable people to do it at home. virtual dance platform, whether watch the video recorded for in-person class and do a buddy dance, or remotely attend a live virtual teaching. But the next stage, what I really wanted to do is a personalized recommendation of music and dance based on your health condition or real-time emotion, as well as Match.com for patients, like recommend buddies, groups, and events to you, because research shows that if you're in a team, you're more likely to accomplish your goal, but you really excel when you have the buddy. So my question for you guys is, I love to hear the advice in terms of the data to track for dance, physical activity data. The other one, a huge part is the emotional data to track, because the music and dance benefit, huge part is actually in the emotion. And then emotional health is being really under-addressed in healthcare. And how do we track these two data? What do you think are the important points to track?
If I had to solve that problem by myself, I would ask all of the people that I know that have used the approaches that you're talking about, and pick their brain for the aspects of the experience that were important to them, and start. And so I'm a big fan of sort of user experience research, but I also mostly believe or partly believe what Steve Jobs said about people not necessarily knowing what they want. They know what they need and what they feel. So I think the people that have experienced this, that have worked with you and this kind of approach, have that information in their heads, and you can tease it out of there. So I would do some really intense interviewing of them to figure out what was important about that experience for them, and then start experimenting with how that might be turned into things that are measurable.
And so to Ronnie's point, oh, please go ahead.
For emotional,
Both.
both and as well as physical.
Mm-hmm.
Yeah, so I have a challenge, like when I was trying to figure out how to do this, because my background in healthcare is mostly as a patient, not as a clinician. So that's the part I'm struggling with. These studies are published for years because of summarization. However, these are most self-report data. In our modern standard, we need sensor data. And then if you're using sensor to track, there's another issue, because I don't feel I'm comfortable to ask our patient pay $100 to get a tracking device to help them track. Like right now, our platform is just you have a computer, you have a camera, then you can use it. But then to add the device tracking data, not just self-report data, which is according to the modern standard, that's kind of like a challenge, both the cost side as well as the method.
So one thought for you, there is a company called Ginger.io, and they've decided that this is too hard, so that they'll use proxies for that kind of sensor data. So how many times do you look at Facebook every day? Probably when you're sad, not very often, but when you're happy and vigorous, probably more often. So they'll count the number of times you open Facebook, or tweets you send, or emails you respond to, or your email response time. And this becomes a proxy for your mood. That's maybe something to investigate. Do interviews and figure out the right proxy for your mood.
We actually have a pilot with Ginger.io, and we're finding some profound implications of being able to monitor emotional state based upon some very elaborate analytics on hundreds and hundreds of data points, like John described. So it actually does work. To your point about the neglect of dance and art and the soft side of, if you will, of science and how we address that, I think that the difficulty in that is not that it doesn't work. It's profoundly therapeutic for many people, meditation being a simple example that is studied and shows massive benefit. But I think it's true for all the arts. The personalization of that to the individual, knowing what to prescribe and knowing how to support it and sustain it, how to create the motivational and behavioral milieu. It's what I call the behavioral symphony of wellness, to bring together multiple inputs from multiple sources to help people make the decisions and do the activities that bring about healthier living. Because after all, health is a subset of happiness. There are lots of people who are healthy but not happy, and lots of people are happy who are not healthy. And so how we create a science around your question, I think, is one of the profound opportunities of this century. And the Dalai Lama has written extensively about this. Brilliant writing. And so I think that the ability to take patient-generated health information, to look at the crowdsourcing and the social influence and the behavioral sciences of how you integrate non-data-driven, non-pharmacologic interventions into various disease states is going to be one of the profound opportunities. Fareed Zakaria interviewed one of the pioneers in this space just a couple of weeks ago, and there's a lot of data that the health of your social network and the amount of love that exists in your life is one of the biggest determinants of your health and happiness. And Dean Ornish is the one who's pioneered this work, and it's just there is data there to support it. How we personalize it for individuals and how we maximize that social support, I think, is a huge opportunity. And what Ronnie's doing with his application and others, I think, are going to take us down that path.
I would just add one quick thing I just want to make sure we get enough time for other questions. I would find potentially a physician or caregiver that can partner with you to help you structure the data and the semantics of it, so that there's a translational bridge there. And also, I wanted just one comment, which is, you started a company within 2 months of your cancer treatment. That's awesome. Dr. Small.
Thanks, first of all, for the great panel. I'm wondering, and I'm addressing this question to the three of you, if you might comment a little bit on...
By the way, Dr. Small is the chairman of oncology here.
If you might comment on the impact of precision medicine, genomic characterization, leading to more, not less, health disparities, to the issue of democratization of this process. Dr. Shuman and I take care of patients at San Francisco General Hospital, and probably the most important question you can ask in the medical history is, are you housed? Do you have someplace to live? So, this is incredibly powerful stuff, but I worry about the democratization. I'm hoping that you can speak to that. And I would argue that our environment here at UCSF, just as the environment at the Beth Israel, I've been there, is a pretty elite environment.
Great question, and I'm a fan also. I believe housing is more important than the genome.
And so, again, it's about economic incentives in some ways. With Massachusetts having universal health care coverage at this point, and with all these risk-based contracts, we've started doing telemedicine, teleservice, home care visits that are looking at not so much the science and the medicine, but who are you living with? What's in your refrigerator? What are the social dynamics contributing to your lifestyle and capacity to be healthy? Because what we were discovering when we do risk-adjusted analysis of our 200 super utilizers, it's actually more social than it is directly medical. We are starting to pay more attention to that because we're incented to do so.
So there's a group that meets annually called the Framework for Humanity, which takes this issue on very directly, and the health implications of the social determinants of health and how to level the playing field for social disparities. And so one of the ways that I like to think about answering your question is, how do we build an evidence basis for addressing the social disparities in health, more along the lines of how we study a drug? So it's actually very complicated, because you need to understand the needs of a community from the perspective of all the social determinants of health. You need to be able to do a gap analysis and benchmarking against other communities. So you need a survey that's easily administrated and that is validated to be comparable between communities. You then need to go to the leaders, both formal and informal, of that community and say, what is your app? First of all, do you validate what our survey finds? Is this list of contributors to social disparities a valid list? And then what's your appetite for change, and then what are the resources available, and then all of the NGOs and the foundations that are trying to address these social disparities, they all have a hammer, and everything looks like a nail to them, but they each have different hammers, but yet everything looks like a nail. And so how do you develop the sequence and the ensemble of tools that addresses the priorities and the appetite and the capacity of a community to take on those issues in an evidence-based framework, so that you can then have validated gaps, validated appetite, validated capacity, and a validated ensemble and sequence of tools to address those social disparities. So to John's point, until you have universal health coverage, you can't even get to that level of community conscious thinking. One of the great misnomers in public health is that because income of a community is the best predictor of the health of that community, that somehow that's a secret cause-effect relationship, and there's nothing we can do about it, because how do you affect the income of a whole community? Well, in fact, it's actually the roll-up of the final common pathway for all of these other disparities. 50% of homelessness is based upon bankruptcy from medical conditions, as one example, as you well know. And so we really need to apply the science of evidence-based medicine to evidence-based social determinants of health, so we actually have a validated methodology for addressing those issues. But in addition, universal health coverage becomes more of a sine qua non to even enable that kind of thinking and that kind of community response. But I think, so long as Obamacare is not overturned, I think we have a shot at getting there. You look at a country like Singapore, which has taken this on. They have a third the cost of their healthcare system that we do, and they're number 6 in the world in terms of health outcomes. And we're way down there next to Serbia. So we have a lot of opportunity to give more for less if we have the enabling framework of universal health coverage. And thankfully, Massachusetts has found a way to it earlier and can serve as a model. But I think there's reason to be optimistic, but only if we get to the universal coverage that almost every nation outside the U.S., every developed nation has.
I'll add something brief, and that is that I do think it's going to get worse before it gets better, because the people who have the louder, more sophisticated, coherent voice are the ones that are looking for are willing to pay for or cause to be paid. Sort of what I think of as the equivalent of, I remember during my residency training here, I probably got 100 hours worth of training on how to use complicated, expensive IV anticoagulants for acute coronary syndromes, and about 15 minutes of training on using the aspirin that's 40 times more effective than any of those, but not nearly as sexy. And but partly because we'll continue to have awesome people who go into medicine and ask questions like this one, we'll be reminded to apply the things that the innovative spirit, which in some part comes from that imperfect, uneven distribution of resources, that will teach us how to do things like how to sequence cancer's genome, but then as a close correlate will allow us to hopefully soon do an extraordinarily better job with things like schizophrenia, which probably accounts for most of those medical bankruptcies. And so I think it's hard to imagine a future where there are relatively less disparities, but I suspect and hope that we can improve everyone's lot so that we're all doing a whole lot better than we are now.
Let me just add one other thing, because if you look at what Clay Christensen has written about, is all new technologies start off as expensive, centralized, expert-based systems that then become commoditized, dematerialized, democratized. The accelerating rate of innovation is, to Ronnie's point, I think it's exaggerating the problem on the path to improving it. But if you look at the book Infinite Progress by Byron Reese, or you look at Bold by Peter Diamandis, and the consequences of exponentiality and the history of raising the tide for all boats, there's no question that there's reason to be very optimistic about that changing because of the exponentiality and the democratization of technology. But I think the faster we innovate, the more the disparities grow as a lag phase phenomenon, but not as an end state phenomenon. So that there's always going to be this lag, but I think the boats at the bottom of the sea are still rising faster than ever before, and I think
it's a great point. For example, half the world's population, including 30% of those that don't even have running water, will have a cell phone. right, within
Right.
2 years. So technology can definitely make a difference. And there was initially disparity, right? Cell phone was a rich person's device, but technology can catch up, right? And Dr. Shuman, did you have a question?
Well, comment.
Comment.
Question. First, you guys were fantastic. I'm humbled by your knowledge and insights, and I genuinely mean that. Second is a question, and one of you alluded to this, but one of the problems I see in implementing this approach to medicine is how well trained are physicians to maximally take advantage of this. Being Lucy is here. So how much of the medical curriculum prepares medical students to optimally take advantage of this incredible technology? And I'll add parenthetically, and while Dr. Rowe is not here, could perhaps answer it. So the interns and residents, how prepared are they for implementing that? Or physicians who are already practicing? I am fearful that as brilliant and as wonderful as this type of IT technology is, there'll be problems in implementing it with physicians. So how do you see that evolving?
So I enrolled as a student at UCSF in the MSTP program in 1984. And I was taught how to be a doctor, but I was not taught the profession of medicine. I was taught the Krebs cycle and not the revenue cycle. And so probably, if you ask, how many times have I used the Krebs cycle as a practicing physician? Oh, that would be 0. We should look at what we are teaching, and is there a process we should teach about how you are going to engage in goal-based care? How are you going to use the new tools that we have available to us? Because, the traditional memorize and regurgitate approach that was used in my era, I'm sure it's not used now, is no longer necessary, because we should all be knowledge navigators and data miners and not memorizers. So I'm sure your new curriculum does all that.
I would just add one comment to that, which is I think a really disruptive technology should be user obvious. So it doesn't require massive total reform of the educational system. And it's hard to do that, right? But I mean, an example of that may be the iPhone, right? Or Facebook. So I think if you have the right technology, it can adopt itself even without total overhaul of the educational system.
We started a program about 4 weeks ago, maybe 5. The backstory, I can point you to a blog post that I wrote about it. But the goal was to try to figure out how to get clinicians and researchers to have a better sense of what this happened to be the context happened to be cystic fibrosis. And the goal was, how do we get clinicians and researchers to have a better sense of what this darn thing is like? There was a big meeting. We were redesigning the care system, and could only have one patient there in person because of infection control concerns, because CFers have really nasty pulmonary infections that often have complicated resistance patterns. And so out of necessity, we sort of made up this idea. And even though it only started 4 weeks ago, we're now already on our 4th disease that we're doing it in, and it's about to be incorporated into a medical school curriculum. And the simple idea is we pair up teachers, which in this case are patients or caregivers. So we did 7 CF, 5 people with CF, adults with CF, 2 parents of kids with CF, and each was teamed up with a learner who was a clinician or researcher or other interested professional. And we built CF kits, and this is just version 1 of the kit was built, and it consisted of the handheld part of a nebulizer that you can buy online for $15. Not the big expensive condenser, but just you had to tie the nebulizer to a table so that you could simulate it not being very mobile, and a extra small vest that you had to put on and just barely able to zip up to remind yourself that it's not that easy to breathe. You can breathe, but it's sort of conscious. And then for one day, and One Day is the sort of the name of this project, for now at least. Each of those learners, that happen to be professionals, was paired with their CF buddy, and their CF buddy, most of them used SMS, some used email, texted them everything they had to do or think or worry about over the course of the day, about their own CF or in a couple cases of their kids' CF. And the amount of learning that's happened in these 7 individual days. I was one of the learners. I didn't think I needed this, but I felt like if I should do it just to sort of be, part of the gang. And I learned so much that I'm still processing. The most important learning point for me was I didn't leave enough time for my post-workout nebulizer treatment, and between that and the rare date I had with my wife. And I really had to go on this date with my wife. I wanted to and I needed to. And so I was texting with my CF buddy about my guilt, about missing my nebulizer and kind of letting him down. And he taught me a lot about how that, in fact, is one of the most important parts of his everyday, is negotiating what is going to be done perfectly, what is going to be compromised a little bit and maybe made up for the next day so that he can have a little bit of balance. And this is done with ubiquitous technology. Frankly, nothing new. We used SMS, email, and Twitter, all of which are in production. And I think it's a great reminder of how when it comes to how are we going to let medical students figure out how the practice of medicine involves informaticians, I should probably recruit John and John to be 2 of the teachers for the next cohort of medical students to learn what it's like to deal with, the complaints of 8 minutes of downtime a year or whatever it is. And so I think a lot of this is enabled by technology, but ends up being about, can we be smarter and more thoughtful about learning from each other efficiently?
Beautiful. Is there any other questions?
Let me just add one other thing. I think the medical student in the future is going to have to be much better trained about how to ask the right questions and to come up with the right answers and how to crowdsource the questions that they ask. And that's a difficult skill to acquire if you weren't raised by parents who actually use that method of teaching. And so I think we're going to have to develop a science about how to condition coming up with the right questions for the right problem, and how to crowdsource those questions that is different than anything in the traditional medical education.
Because 50% of what I was taught at UCSF is wrong. I just don't know which 50%.
On that note, thank you, everybody. We're running a little late. And thank you, Dr. Shuman, for making this possible, and the Grove Foundation.